So hello and welcome to this emergency medicine podcast on the primary and secondary surveys. During this podcast, I'm going to do a basic overview of what the primary and secondary surveys are, and I'm then going to look at them in more detail, considering the different ways that you can assess and manage each component of these surveys. So firstly, the primary survey. The aim of the primary survey is to quickly assess a patient in the initial stages of trauma management. The primary survey contains the familiar ABC process mnemonic that we all know so well from basic life support. However, in this podcast, what I want to try and do is to look in more detail at each component of the primary survey and to add some other components. So, another way of thinking of the primary survey is not in ABC, but in terms of doctors A, B, C, D, E. Now let me just go through each of these components. D stands for danger. So you need to ask yourself the question, are you or the casualty in danger? Often this will not be the case because you'll be in the emergency department. The next is response. Is the patient conscious or are they unconscious? If they appear to be unconscious, then you need to do three things. Speak to them, saying, "Can you hear me?" Next, giving a command, saying, "Open your eyes." And finally, shaking the shoulders gently to see if they respond to the stimulation. The S following R for response stands for shout for help, and is useful to have in the emergency department in your mind as well, because it's a reminder to review constantly which specialities you need to get involved in the care of the patient. So we then move on to A, B, C, D, E. For A, B, C, it's useful to do a split for each one. So each component composes an assessment process and a management process. So going through airway first. If there has been trauma, then it's very important to protect the cervical spine until you have shown clinically and radiologically that it is clear. In terms of assessment of the airway, your basic need is to assess, is the airway patent? A couple of useful rules here. If the patient is talking, the airway is patent. Partial airway obstruction is suggested by stridor, gurgling, or snoring. Complete airways obstruction is suggested by silence. The basic aim in managing the airway is of course to establish a patent airway, and there are a number of ways with which you can do this. Most simply, you can look in the mouth and possibly use suction if there's an obvious obstruction there. You can then do the chin lift or jaw thrust. In addition, you can insert a naso or oropharyngeal airway. You can intubate, thus placing an ET tube, or finally you can do a cricothyroidotomy. It's worth mentioning here a couple of indications for intubation, or situations where you might want to think about intubating. These include airway or breathing compromise, an unprotected airway, or a GCS less than 9. There's going to be more on the Glasgow Coma Scale later. So now, moving on to breathing. Once again, we can break breathing down into assessment and management. In assessment, we need to look at a number of different things. Firstly, you're looking at the respiratory rate, and this is possibly the single most useful marker of critical illness. Next, you want to check bilateral chest movement, position of the trachea, percuss the chest, and auscultate. Particular things to be aware of are pneumothorax, that's either normal pneumothorax or particularly a tension pneumothorax, as well as chest wall abnormalities such as sucking chest wounds and flail chest. In the management of breathing, it's important first of all to know that if there's no respiratory effort, you should treat this as an arrest and therefore call the crash team, intubate and ventilate. If the breathing is compromised, then you need to give an increased concentration of oxygen and manage according to the findings. For example, if you found a tension pneumothorax, you need to quickly insert a cannula into the pleural space. Now we can move on to circulation. So, in assessment of the circulation, you're first of all looking at the patient generally for any signs of hemorrhage. You're then assessing skin colour, temperature, and capillary refill. Next, moving to check pulse, blood pressure, and neck veins. Management of the circulation, obviously if there is no circulation, so no cardiac output, you need to treat as an arrest. If the patient is shocked, then you need to treat according to the cause of the shock. But generally, if you find them to be shocked, you're going to be inserting 2 large bore IV cannulae, using venous cut down if it's not possible to get this kind of access. You're going to be taking bloods, trauma bloods, specifically for blood count, urine electrolytes, cross-match, clotting, and a pregnancy test if the patient is female. And you're going to be giving 1 to 2 litres of saline as quickly as possible, plus or minus blood, depending upon the cause of the shock. Hypotension in a patient should be considered to be hypovolemia until proven otherwise. However, it's important to remember that normotension does not exclude hypovolemia. Moving on to disability now, or D. There are 3 important aspects of assessing disability. These are assessing the level of consciousness, either via the Glasgow Coma Scale or the AVPU system. The second important aspect is to assess pupillary responses, and the third is to look for any lateralizing signs, for example, gross motor differences between left and right. E stands for exposure and basically involves undressing the patient while remembering to cover them up to avoid hypothermia. Lastly, some people teach to also check for glucose at this stage. So we've now completed the primary survey and therefore move on to the secondary survey. The secondary survey basically includes a complete assessment of the patient from top to toe. This should be done systematically and may include reassessment of the primary survey. In addition, the secondary survey includes imaging tests and blood tests. So going from top to toe, you need to examine the head, face, cervical spine and neck, chest, abdomen, limbs, and perineum. This examination should include a PR exam. At this stage, it's also important to try and get some sort of history. If the patient is conscious, this may be possible, but it may be necessary to speak to witnesses or relatives or other people. The mnemonic AMPLE is useful for remembering the most important bits of the history to try and establish. So going through, A stands for allergies, M for medications, P for previous medical or surgical history, L for last meal, and finally E for the events surrounding the injury itself. Finally, it's very important to remember to constantly repeat the primary survey, reassessing GCS, pupils, and other important signs. So in summary, the primary and secondary surveys represent useful approaches to an injured or ill patient. When thinking about the primary survey, remember the mnemonic doctors A, B, C, D, E. Also remember that A, B, C can be broken down into assessment and management. In the secondary survey, remember the mnemonics AMPLE for a quick history, and also that the top-to-toe examination that forms a crucial part of the secondary survey should also be accompanied by frequent reassessments of the primary survey. So that completes this emergency medicine podcast on the primary and secondary surveys.